Welcome to the New England Journal of Medicine at the annual meeting of the European Society of Cardiology. I'm Stephen Morrissey, Executive Managing Editor, and I'm talking with Deputy Editor Jane Leopold and Editor-in-Chief Eric Rubin. We're looking at the popular PAUSE TAV trial, continuation versus interruption of oral anticoagulation during TAV. This is the second TAV trial we've discussed today, but this one asks a different question. Jane, what did the investigators want to know?
So in this trial, the investigators were focusing on about 1/3 of all of the patients that undergo TAV that actually have an indication for oral anticoagulation due to other diseases, mainly atrial fibrillation. Now, international guidelines actually advise that oral anticoagulants are interrupted in patients who are undergoing interventions that have a high risk of bleeding. And certainly that is what TAV is. But the optimal strategy for anticoagulation management in patients undergoing TAV hasn't been well studied. And the thought is that while you interrupt oral anticoagulants during TAV, you may decrease the risk of bleeding, but continuing them may decrease the risk of thromboembolism. So it's really a balance between the two. And there's some information from observational studies that suggests that lower risk of stroke in patients who continued oral anticoagulants during TAV without having an increased risk of bleeding. So the investigators actually wanted to answer this question and do so in a randomized trial.
This was an open-label, non-inferiority trial that randomized participants between continuing anticoagulation through the TAV or stopping before the procedure and resuming again when considered safe in patients who had continuing indications for anticoagulation. The primary outcome was a composite of cardiovascular mortality, stroke, MI, major vascular complications, or major bleeding occurring within 30 days following the TAV. More than 850 patients were randomized, and the primary outcome occurred in more than 16% of the continuation group and about 15% in the interruption group, values that failed to meet the criteria for non-inferiority.
Jane, what's the biggest risk associated with the continuation strategy, and how do you think this affected the results?
Yeah, that's a great question. The biggest risk, obviously, is bleeding. And that's because we're talking about having patients on an oral anticoagulant, and we're talking about a procedure where we're using really large bore access into large vessels. So, when you look at the data, in fact, there were numerically more vascular access complications and major bleeding events among patients assigned to the continuation strategy compared to the interruption strategy. And this is in part why some institutions have a policy where they hold oral anticoagulants prior to these kinds of procedures. Now, while there were numerically more strokes in the interruption strategy group, we don't know if this was related to the TAV procedure and mechanical disruption of plaque or calcium, or if this was an atrial fibrillation-related embolic event. So, we're left with the data we have, but we now finally have randomized data that tell us that continuing oral anticoagulants with TAV is not non-inferior. So I think this can help inform future procedures.
Now, Jane, this is a cardiology conference, and so the procedure we're talking about is a cardiac procedure. But do you think you can extrapolate from these results to other sorts of procedures that patients who are on anticoagulation might be having?
Probably not. And I say this because we're talking about a cardiology procedure where we're directly accessing the vasculature with a large bore sheath. So when we do this, patients are at increased risk for vascular access complications and bleeding events. Other procedures that don't require accessing the vasculature, things may turn out quite differently. So I think this will need to be studied in context-specific ways in order to answer that question.
Thank you, Jane, and thank you, Eric. This study was just published at NEJM.org.